Good day, everybody. Today we are going to talk how to approach a case of acromegaly. Acromegaly is a chronic disorder caused by growth hormone hypersecretion. Growth hormone circulates and stimulates the production of insulin-like growth factor 1 from the liver and systemic tissues. Insulin-like growth factor 1 in large part mediates the somatic and metabolic effects of growth hormone. Excess growth hormone leads to excess production of IGF-1, leading to the multi-system disease characterized by somatic overgrowth, multiple comorbidities, premature mortality, and physical disfigurement. Over 95% of the patients with acromegaly, the cause is a growth hormone-secreting pituitary adenoma. Hypothalamic tumors or neuroendocrine tumors, usually from the lung or the pancreatic origin, may lead to the somatotroph hyperplasia and acromegaly mediated through growth hormone-releasing hormone. Very rare, ectopic growth hormone production by an abdominal or a hematopoietic tumor can cause acromegaly. Clinical features of acromegaly include physical changes like prominence of the eyebrows, enlargement of the nose and lips, prognathism, soft tissue hypertrophy, microglossia, hyperhidrosis. In addition, local tumor effects like headache, visual impairment, associated hyperprolactinemias, or associated compressive manifestations like hypopituitarism. Metabolic and endocrine complications include impaired glucose tolerance or even diabetes mellitus, dyslipidemias, and goiter. Gastrointestinal complications include colonic polyps and colon cancer. Reproductive disorders like menstrual disturbance or erectile dysfunction in men. Cardiovascular complications include hypertension, congestive heart failure, biventricular hypertrophy, or cardiomyopathy. There is also associated respiratory complications like obstructive sleep apnea. Skeletal system complications like increased articular cartilage thickness, carpal tunnel syndrome, arthropathy, or even vertebral fractures. To diagnose a case of acromegaly, the Endocrine Society Clinical Practice Guidelines published in 2014 recommended the measurement of IGF-1 as a screening tool for acromegalic patients. They recommended the measurement of IGF-1 in all patients with typical features of acromegaly. In addition, patients with atypical features of acromegaly but have diabetes mellitus, hypertension, arthritis, carpal tunnel syndrome, hyperhidrosis, or sleep apnea should be screened for acromegaly by using the IGF-1. A normal IGF-1 level effectively excludes the diagnosis of acromegaly. We may have false positive results as in pregnancy where there is a growth hormone variant and in late stages of adolescence. Falsely elevated or normal or low IGF-1 values may be encountered in patients with hepatic failure, renal failure, hypothyroidism, malnutrition, severe infection, poorly controlled diabetes mellitus. False negative results in patients taking oral estrogens. The liver becomes less responsive to growth hormone, resulting in lower IGF-1 levels. It's important to take into consideration that IGF-1 level decreases with age following adolescence. Therefore, all levels must be assessed in relation to age-appropriate normal values for specific assay being used. Measurement of growth hormone as a random value has no role in the diagnosis of acromegaly. In patients with elevated or equivocal serum insulin-like growth factor 1, they recommended the confirmation of the diagnosis by doing the growth hormone basal level and then after glucose suppression test, by doing the oral glucose tolerance test. The diagnosis is confirmed by lack of suppression of growth hormone to less than 1 microgram per liter, following a documented hyperglycemia. Pituitary MRI remains the cornerstone for the diagnosis of a pituitary mass. It is recommended for patients with acromegaly to ascertain the tumor size, location, and invasiveness. Microadenomas are detected in up to 77% of the They suggested that the patients having a pituitary adenoma that is encroaching or approaching the optic chiasm, they must be tested by perimetry to check for the visual field effect. All patients presenting with acromegaly should be screened for associated comorbidities because these patients have twice the risk for increased mortality. They have 15 to 38% increased risk of diabetes or impaired glucose tolerance, 33 to 46 increased risk for hypertension, 96% increased risk for sleep apnea. Patients with acromegaly are also at increased risk for colon cancer, so the patients should be screened by colonoscopy. Another type of cancer that is more common in patients with acromegaly is thyroid cancer, with around 7% of the patients having thyroid cancer, with papillary thyroid carcinoma the most common type. 54% of the patients have thyroid nodules. It has been found that the disease duration correlates with the number of nodules. Around 20% have diffuse goiter. So thyroid ultrasound is suggested if a palpable thyroid nodule is found. Hypopituitarism may occur due to tumor compression or as a result of surgical or radiation treatment. So they recommended assessing for hypopituitarism and replacing hormone deficits. After diagnosing case of acromegaly, what are the options for treatment? First of all, we have to know the goals. The goals are having a normalized serum IGF-1 level and a random growth hormone of less than 1 microgram per liter. They suggested that maintaining the same growth hormone and IGF-1 assay in the same patient throughout management. Surgery is the primary therapy in most patients, with transsphenoidal surgery, if possible, is the preferred option. Transcranial approach remains another option for patients having large adenomas. Initial remission rate is 85% for microadenomas and 40 to 50% for macroadenomas. 5-year disease recurrence rate ranges from 2 to 8%. If a patient has a recurrent disease, repetition of surgery is a primary option. Then, how we are going to follow the patient? To detect remission, measurement of IGF-1 or random growth hormone at 12 weeks or later is recommended. A normal IGF-1 value and undetectable growth hormone value are sufficient for indicating surgical remission. Growth hormone value less than 0.14 microgram per liter suggests surgical remission. Serum growth hormone less than 1 microgram indicates control and normalization of the mortality risk. Patients having growth hormone greater than 1 microgram per liter should be tested with the oral glucose tolerance test. They recommended performing an imaging study at least 12 weeks after surgery to visualize residual tumor and adjacent structure. MRI, the imaging modality of choice. Are there any other therapies? Medical therapy is recommended in patients with persistent disease following surgery, provided that there is no local compression. If the patient has mild to moderate symptoms, dopaminergic agonists are the drugs of choice. If the patients have moderate to severe, somatostatin receptor ligands or bevacizumab is another option. They suggested that somatostatin receptor ligands can be used as a primary therapy in patients who cannot be cured by surgery, has extensive cavernous sinus invasion, does not have chiasmal compression, or is a poor surgical candidate. Radiotherapy is another option. It can be used in a patient having residual tumor mass following surgery, and if medical therapy is unavailable, unsuccessful, or not tolerated. In this setting, stereotactic radiotherapy is a preferred option. So we have the transsphenoidal surgery as a primary therapy, the drugs. There are a lot of acromegaly. But back to physiology, I have to know that somatostatin is a cyclic peptide of 14 or 28 amino acids with a short half-life less than 3 minutes. Somatostatin producing cells can be found in the central nervous system, peripheral nervous system, and in the endocrine, pancreas, and gut. At the level of the pituitary, the main effect of somatostatin is the inhibition of both growth hormone secretion and cell growth. Somatostatin receptors are 5 7-domain G-protein coupled receptors, named from 1 to 5. The normal adult human pituitary gland mainly expresses somatostatin receptor 1 and 2, 3, and 5, with somatostatin receptor number 5 being highly expressed, followed by 2, 1, and 3. Somatostatin receptor 2 are expressed in 95% of growth hormone secreting pituitary adenomas. Somatostatin receptor 5 are expressed in 85%. Somatostatin receptor 1 and 3 are expressed in around 40% of the pituitary adenoma. There are two generations for somatostatin receptor ligands. The first generation include the octreotide and lanreotide, predominantly acting on somatostatin receptor number 2. Second generation, the pasireotide, is a multi-ligand acting mainly on somatostatin receptor 5 and 2. As we previously mentioned, that the first generation have high affinity to somatostatin receptor 2, with the longer acting formulation may reach up to 1 month of action. The second generation, the pasireotide, is the novel multi-receptor target somatostatin receptor. Pasireotide has a higher affinity for receptor number 5, but also acts on the 2, 3, and 1. Pasireotide being a multi-receptor ligand, it produces higher response rates. It inhibits growth hormone secretion, so produces disease control. It also produces tumor shrinkage, so facilitates surgery. But unfortunately, it inhibits GLP-1 and insulin secretion that may produce hyperglycemia and diabetes. It also inhibits cytochrome B450, so there may be some drug interaction. Initially approved by the FDA for patients who considered uncontrolled after surgical treatment for Cushing disease, but 2 years later in 2014 it was approved for treatment of acromegaly. What is bicprisumab? It's a human growth hormone receptor antagonist. So we have to know that it antagonizes the effect of growth hormone on the liver, decreasing the production of IGF-1, but growth hormone hypersecretion persists. It produces a favorable benefit for glycemic control. Tumor growth may occur in 3 to 5% of the patients due to tumor natural history or due to decreased negative feedback by the lower IGF-1. Dopaminergic agonists suppress growth hormone secretion only modestly in most patients and are now replaced by somatostatin receptor ligands. However, they are much cheaper and they can be taken orally, so they can be used as adjunct to insufficient somatostatin receptor ligand therapy. Dopaminergic agonists have been reported to be more effective in adenomas that co-secrete prolactin, which express more D2 receptors, the main site of action of the dopaminergic agonist. Cabergoline is more effective and is more preferred than promocret. There are a whole list of medical therapies that can be used for acromegaly, but all of them still under development. Thank you.